Okay, thanks so much. Thanks again for the invitation to be here and for the very kind introduction. I wanted to thank Colleen and the rest of the team at the Town of Dryden for inviting me to be here to speak with you today. And to Kim Mitchell for initially making the connection between us. I do apologize, I'm not actually there in person. I'd like to come up sometime and visit. That would be lovely. But for now, for today, I'm actually speaking to you from the traditional territories of the Mississauga and the Haudenosaunee nations from Hamilton, Ontario, which is within the territories that are protected by the Dish with One Spoon Wampum Agreement. My expertise is in chemistry in particular and in radioisotope research and production. And I've been in the nuclear medicine, radiopharmaceutical development space for a number of years now. So that's really where my core expertise sits. So I was sent a number of questions from the town of Dryden about what some of your interests are in better understanding what nuclear medicine is and how it's related to nuclear power. I unfortunately am not able to see my slides right now, which is leaving me a little lost. Trevor, are you able to tell me how I can see those? Control the slides, or is that something you have to do? There we are. Thank you so much. So if we could go to the first slide, please, or the next slide. All right, so MAC, we're located in Southern Ontario, and we've had strong research programs in nuclear science and engineering all the way back to the 1950s. So something we're known for these days is our nuclear research reactor, which is Canada's most powerful nuclear research reactor. And it's also a major producer of medical isotopes for use in cancer therapy. So my group is focused on helping to provide radiopharmaceutical researchers with early access to next generation isotopes so that they can help to develop the drug products of the future for personalized medicine, particularly around cancer care. So the next slide just shows the list of questions that I received from the organizing committee. And a lot of these questions are just looking at how does nuclear medicine interface with nuclear power? What does that have to do with used nuclear fuel? What does that have to do with the deep geological repository? And sort of what is the interface between nuclear medicine, cyclotrons, nuclear research reactors, and power reactors. So rather than sort of go through a long list of questions and try to answer them all specifically, what I thought I would do today is to try to give you an overview of nuclear medicine and some context that hopefully will help to answer these questions by the end of our sort of 45 minutes together. And if we don't, I've got my email address on the last slide, and I'm happy to answer questions at any time, either today or in the future. So on the next slide, we have a very simple question, which is what is nuclear medicine? The answer to that is the use of nuclear materials in medicine, which is not a super helpful definition unless we're clear on what nuclear substances are or what radioactive substances are. So our next slide just has some graphics that will hopefully just make sure we're all on the same page when we're talking about what nuclear materials are and how we would potentially use them in medicine. So as most of us probably know, the whole world is made up of matter, whether that's the chair you're sitting on, or it's the computer screen that I'm staring at right now, or it's the glass of water you had at the break. Everything is made up of materials. And materials are made up of chemicals, also called molecules. So if you've got a glass of water, it's full of water molecules. The glass itself is made out of borosilicates and so on. So that's matter at the macro scale. A cup of water has millions and millions of billions of molecules of water inside of it. So molecules are very, very small. And each molecule is made up of atoms that are bonded together to form that molecule. So breaking down the molecule even more, we look at the atom. So each individual atom it's a little world of its own. So it has a center called a nucleus that contains protons and neutrons. And then there's a bunch of electrons that sort of orbit around that nucleus in a bit of a cloud. So when we talk about nuclear materials or radioactive materials, what we're usually saying is we have an atom that has a nucleus that has too much energy in it. So somehow the protons and neutrons are energized, they're in a high energy state, and the atom doesn't like that. It's a radioactive atom, a radionuclide, radioisotope, whatever you want to call it. It's an atom and its nucleus has too much energy. So it does the same thing that you or I do when we have too much energy, except instead of going jogging or kickboxing or something like that, what a radioactive atom does is it gives off radiation to get rid of that excess energy. And different radioactive atoms give off different types of energy. So maybe it's alpha particles or beta particles, maybe it's gamma radiation. They can give off all different types of radiation. They can do this quickly, they can do this slowly, as Peter was just talking about. Some of them are very, very long lived and live for a long time. Some of them only survive for microseconds or nanoseconds. So it can be a fast or a slow process, depending on the particular radioisotope that we're looking at. So on the next slide, what we're going to look at is how this affects how we use radioactive materials in medicine. So these radioactive materials have different types of radiation, and these different types of radiation interact differently with different materials. So on the far right-hand side of the slide, you can see just a little example of an alpha particle, a beta particle, and a gamma ray. And they're all traveling in the same direction, and they hit a piece of paper. The alpha particle stops. The beta and gamma go through it, and then they hit a piece of aluminum. The beta gets stopped by that aluminum. The gamma doesn't. It goes all the way through until it hits the lead. So different types of radiation have very different interactions with matter, and that's what we use in nuclear medicine. Some radioisotopes are going to give off energy that's good for imaging. Some radioisotopes are going to give off energy that's better for therapy, so for destroying tumors and so on. So when we look at a particular radioisotope and we think, is this good or bad for use in nuclear medicine, what we're asking ourselves is it giving off particles that are the right energy to do something that we want to do? Maybe diagnose a disease, maybe treat a disease. And then does it have an appropriate half-life? If we're administering radioactive substances to people, we don't want them to be radioactive for days and days and days. But we do need to have enough time to make that drug and get it administered to the patient before the radioisotope disappears. So where do the radioactive materials that we use in medicine come from? They come from the deliberate production of these radioactive substances, usually in nuclear research facilities. So you can make an atom radioactive by taking just a stable atom and adding a high energy particle to it. So the nucleus of the atom contains protons and neutrons. If you take a really fast moving neutron and slam it into the atomic nucleus, it'll get absorbed. But now you've got too much energy in that nucleus and it wants to give off energy. So the way we make radioactive isotopes is by adding something to the nucleus. And the two main ways we do this are either using nuclear reactors or using a type of particle accelerator that's called a cyclotron. You can think of a nuclear reactor, particularly a nuclear research reactor, as a source of neutrons. It's got a bunch of nuclear fission happening. It's releasing lots and lots of neutrons. So you can put samples inside your nuclear research reactor and expose them to neutrons. On the other hand, you could take your sample over to a cyclotron. Cyclotrons are great for making charged particles like protons, deuterons, sometimes alpha particles. The reason that we use both nuclear reactors and cyclotrons is that they're complementary production techniques. So you have a nuclear reactor, whether that's a nuclear research reactor or a nuclear power reactor, it still has neutrons. And if we take the example of yttrium-89, which is the example I've shown in the center of this slide, if you take yttrium-89 and you add a neutron to it, you get a radioactive form of yttrium called yttrium-90. Yttrium-90 is used to treat liver cancer. So it's an important medical isotope. If you start off with that exact same stable yttrium-89, and instead of taking it to a nuclear reactor, you take it to a cyclotron, the cyclotron is going to add a proton to that yttrium. And the yttrium turns into zirconium-89, which is also radioactive, but it's not used to treat cancer, it's used to diagnose cancer. Right, so you've got the exact same substance, this yttrium-89, and you can either treat it in a nuclear reactor, research reactor, or power reactor, or you can treat it in a cyclotron. And depending on which type of particle you add to it, you get a different medically useful isotope. So that's why we want to always make sure that we have access to both nuclear reactors and cyclotrons so that we can make the widest possible array of radioisotopes for use in medicine. Next slide, please. So we're not going to go over this slide in detail. This is my quick overview slide. If you want to know how radioisotopes are used in medicine, basically this slide wraps it up. There are a number of different applications. We're going to talk about them for the next 20 minutes or so, not in tremendous detail, but just to help you understand, one of the key questions was, how do we benefit from nuclear medicine? What's the point of doing this? How does nuclear medicine make life better for Canadians? And that's what we're going to try to answer in the next 20 minutes, half an hour. So radioisotopes can be used to help diagnose disease or to treat disease. And there's lots of different treatment modalities. There's radiopharmaceuticals, there's brachytherapy, there's radioembolic therapy. These are all used for different types of cancer, and they also use different radioisotopes depending on what's most appropriate for the particular patient and the particular condition you're trying to treat. So on our next slide, we're going to start off by looking at diagnostic agents, sometimes called diagnostic radiopharmaceuticals. Often if you go to a hospital and you look for the nuclear medicine department, this is the type of thing they're talking about. Traditionally, nuclear medicine in a hospital means radiopharmaceuticals to image patients. A lot of the treatment, the radioisotope-based treatments often fall under radiation oncology, not nuclear medicine. But your traditional nuclear medicine department, this is the type of thing they're going to be doing. So what they're doing is they're getting a radioactive isotope that has appropriate properties to be detected outside of a person, and they're attaching that radioactive atom onto a molecule of some sort. Why would you want to do that? Well, you'd want to do that because your radioactive isotope is giving off radiation, and you can use that to trace where that radioactive drug is inside the patient. So you can use it to basically monitor biochemical processes inside a patient. So on my slide, I've got a couple of the most commonly used radiopharmaceuticals that we're going to talk about a little bit more later on. On the left-hand side, we have a molecule called 2-fluorodeoxyglucose. If you studied nutrition or biology, you might recognize this molecule. It looks pretty familiar except for the bright red 18F hanging off the end of it. This molecule is basically glucose. So it's sugar, and we've attached a radioactive fluorine onto it so that we can trace where that sugar is going inside a patient's body. The center image is Tech-99M Medronate, which is sold under a number of different trade names. Don't worry about the trade names. They're always quite complicated. Technetium is a little bit of an oddball chemical element. It's not something that's found in nature. So the technetium is the important part of this molecule because it's the radioactive part. It's the part that we can trace. But what we've really done with this molecule is we've disguised technetium as a phosphate. Look at all those PO4s, POHs sitting on the other sides of the technetium. This is technetium in disguise, dressed up to look like a phosphate. So that when you inject this into the body, your body is going to recognize it and say, oh, this is phosphate. So we're going to send this to whatever parts of the body are currently using phosphate. So for example, if you have a broken bone, bones are mostly calcium phosphate, and your body will see this imaging agent coming and it'll say, oh good, here's some phosphate. We're going to send this phosphate over to where that bone repair is happening. So tagging molecules with radioactive isotopes enables us to detect where in the body these types of biochemical processes are going on. And then by having the patient lying under a radiation detector, we can make videos or take planar still images of where things are in their body at specific times. So our next slide, we're just going to look at a couple of examples of this. So there's different types of scanners. I don't want to get into the physics of nuclear imaging. I don't think it's necessary for what we're going to talk about here today. But typically we talk about PET scans, which everyone has heard of, and we talked about SPECT scans, which people by and large haven't heard of, which is kind of odd. In Canada, SPECT's actually way more common than PET, but somehow we're all more familiar with the acronym PET scanner. So these are two different types of detectors, and it just depends what type of radiation your imaging isotope is giving off. Some of them are more compatible with PET scanners, some are compatible with a SPECT scanner. But it's all the same process of picking a molecule that has interesting biochemistry, tagging on a radioisotope, and then monitoring where it goes in the human body. So our next slide has a couple of examples of that. So why would we want to do this? This seems like a lot of work. Why don't we just take an X-ray of someone or put them in a CT scan or get an MRI, something like that? What is the added value of doing nuclear imaging as opposed to just taking pictures of people with an X-ray camera? So that's what I'm going to try to look at for the next couple of minutes. The key to diagnostic imaging with nuclear materials is that we're able to get what's called functional imaging, not just structural imaging. So we're not just getting a static image of the structures inside someone's body, like their ribs, their ankles, their bones, cartilage, and so on. What we're getting is a snapshot of the biochemistry that's happening inside their body, which can be tremendously revealing. So this is a case study from a Radiopedia website, which is designed to teach radiology students about imaging techniques. So the case study presents with, we have a 25-year-old woman who goes to her doctor because she has persistent heel pain. So the doctor prescribes an X-ray, which is a type of structural imaging, to check to see maybe she's got a broken bone or something dislocated. So on the left-hand side of the screen, we're looking at an image of this woman's right heel. If you're familiar with X-rays, this looks pretty normal. There's really no sign of a problem here. Her heel looks okay. There's no sign of obviously broken bones. So based on this, the physician says, you know, everything looks fine. But everything's not fine because her heel keeps on hurting. So she goes back to the doctor and says, you know, we need to do a follow-up because, you know, I tried resting it and icing it and it's not really helping. So what we do then is we do diagnostic imaging using a radioactive tracer. Because we're not seeing anything at the structural level, maybe there's something wrong at the biochemical level. So the right-hand side of the screen is showing the results of the nuclear imaging using technetium-99m, so a radioactive imaging technique. And what we're seeing here is in this woman's right heel, there's a very high uptake of this tracer. So what we're seeing at the biochemical level is that this woman has a high uptake of a radiotracer, which is associated with bone maintenance. So although we can't see anything wrong on the structural image, at the molecular level, there's something wrong with this woman's heel. So if you're a radiologist and you're an expert in assessing these sorts of images and making a differential diagnosis, the diagnosis for this woman is going to be that she has a stress fracture in her heel that you're not able to see on an X-ray image because it's a stress fracture. It's a very, very, very small fracture. So it's not showing up on an X-ray because your heel bone is quite large and quite thick. So it's not surprising you'd miss sort of a hairline fracture. But when we look at what's happening biochemically at the molecular level, we can see her body is desperately trying to heal this broken or fractured bone. So she's seeing high uptake of that in her heel. Okay, so we're getting information about the biochemical functions within her body, not just the physical structures. That's a bit of a niche example. Our next slide looks at the most common application of diagnostic imaging in Canada these days. And this is the use of the technetium agent that's shown at the top right of your screen. It's sold under a number of different trade names, Sestamib, Cardiolite. You might be most familiar with this drug because you might have had a stress test, a cardiac stress test, or known someone who does. It's often just referred to as a stress test. So we know that heart disease is a major cause of illness and death in Canada. We know that an enormous number of Canadians go to emergency rooms every year because they feel funny in their chest, et cetera, et cetera. And we need a way to diagnose whether this person is having a heart attack, whether they're having angina, do they need a bypass, et cetera, et cetera. So we need a way to accurately diagnose how well this person's heart is functioning. And nuclear medicine is a way that we do that. So your heart is mostly soft tissue. You're not necessarily going to see anything on an X-ray. What we do instead is nuclear imaging. So there's a number of different camera angles you can take, and those are shown on the left-hand side. If you're wondering why it looks like rings and sort of horseshoe-shaped and things, the left-hand side graphic is just showing you what camera angles you're using to generate these sort of weird-looking images at the bottom. And they are kind of weird-looking shapes unless you're a cardiologist who's an expert in interpreting these images. So what's a stress test? How does it work? The idea is we want to understand how a patient's heart is functioning when they're at rest, and then what happens if you stress the heart. Is it able to supply more blood and therefore more oxygen to the rest of the body or not? So what you typically do is you'd prepare a patient dose of radiopharmaceutical. You would inject that into the patient, and you'd do a series of images with the patient just at rest. You'd then ask the patient to run or walk on a treadmill, depending on their level of physical fitness, and then you'd record a second set of images. This is not the clearest set of images, but if you look at on the right-hand side, the rest images versus the stress images, you'll notice that on the stress images, the lower portion of the image is actually much narrower than on the top. So we're getting a sort of a bulging and a distortion of tracer uptake when this patient's heart is stressed. And what that's basically telling us is that this patient's heart is really struggling to provide sufficient blood flow to the entire organ. So our next slide just shows us how you would go about interpreting that data. So what this is showing us is that there's a particular part of the heart muscle that is not getting enough blood or enough blood flow through it, and therefore enough oxygen through it for that heart muscle to function properly. So there's less functioning of that part of the heart because there's not enough blood getting to it, because there's a blockage of the artery. Okay. This is not an extreme example. This is a patient who is having some impaired blood flow. You can see some of these images where the stress test basically is only one side of the image, not both sides of the image. It can be quite severe. So if you're a cardiologist or a nuclear imaging specialist, you can look at these sort of rest versus stress things, and you can use this to determine whether or not your patient needs immediate surgery, a triple bypass, or whether this is something that should be managed with, exercise, diet, and that sort of thing. So we're able to actually image how well the heart muscle is functioning, how well it's taking up this tracer. So it's an incredibly important application of diagnostic nuclear medicine. Our next slide is just a quick warning. So diagnostic imaging is often used for cancer patients, and that's what we're going to be showing on the next slide. And I know, I remember, I'm a chemist by training. I build and design molecules. And I remember when I got into the nuclear medicine field, they show you patient scans, and sometimes they can be a little upsetting if you're not accustomed to looking at these types of images. So I thought I would just share a slight warning with you before we go on to the next slide. So our next slide shows two of the most common uses of radiotracers in medicine. So on the left-hand side of the screen, we have a PET scan of a woman who's been diagnosed with primary breast cancer. So on the picture of the body, we see there's a little arrowhead that's pointing towards a large black spot. That's the primary tumor that has been detected by palpation. In other words, there's a lump in the breast that's large enough that the patient can feel it, the surgeon can feel it, and so on. So anytime we're diagnosing someone with cancer, the first thing we need to know is, what is the stage of this cancer? Has it spread? Is it localized? Can we just treat this with surgery? Do we need radiation therapy? Do we need chemotherapy? And that's one of the primary uses of nuclear medicine, particularly with this radioactive sugar molecule called FDG. So cancer cells are basically cells that are growing really rapidly, and they're multiplying out of control. They need an enormous amount of energy. Glucose is energy, sugar is energy. So if you inject a patient with a radioactive form of sugar, it's going to go to the parts of their body that are using a lot of energy. You can actually see just the base of the skull in this woman. Your brain uses an enormous amount of sugar. That's why the inside of the skull looks black, because your brain uses tons of sugar. But what's more disturbing is that in addition to the major black spot, which we know is the primary cancer, there's a bunch of smaller black spots up under this woman's armpit. And what that's showing us is that the cancer has spread from the breast into the nearby lymph nodes. So that's not a diagnosis that anyone wants to get, but it's a diagnosis that the oncologist needs to have, so that the oncologist knows how to plan this woman's treatment. So the good news for this patient is we're not seeing anything in the lymph nodes in the other part of the body. It's very localized. So you're probably going to want to remove those lymph nodes, do surgery to remove the primary tumor, perhaps have some radiation therapy, chemotherapy as a follow-up, and so on. But this is telling us that we have to treat not just the primary tumor, but that it's starting to spread. Okay. On the right-hand side, we have a more severe example. This is going back to our technetium disguised as phosphate that we talked about earlier. This is a patient who has been diagnosed by his physician with lung cancer. Lung cancer is often diagnosed later stage when it's spread to other organs. So we can inject this patient with a technetium that's disguised as phosphate, and that radiotracer is going to go to the parts of this person's body where bone is growing rapidly. Apart from children or people who've broken a bone, really, your bones should not be growing rapidly. So all of these black spots, we're seeing a front image and a back image of this patient. All of these areas, these black spots, are cancer metastases. Okay, so this person has lung cancer and it's spread throughout the body and throughout the skeleton. So this is someone who's going to be, this is a terminal situation for this patient, unfortunately. And again, it's not a diagnosis someone wants, but it helps the physician and it helps the patient to understand what their treatment options are, and what their next steps in their life and their personal planning are going to be. Okay, so you can take x-rays of people all day long and you can take CT scans of people all day long. They're not going to tell you that you have lymph nodes that are using too much energy. And they're not going to tell you that you have a bone repair process going on. They're just going to show you someone's skeleton. Okay, the nuclear medicine is what enables us to look at these biochemical processes, which tells us what's going on at the molecular level inside our patient. Okay, next slide. So diagnostic agents are something we have some of the best information for. There's a group called the Canadian Association for Drugs and Technology and Health. They put out a biannual report that does a really great job of documenting all the places in Canada that are doing diagnostic imaging, how many patients they're doing, et cetera, how many scanners there are from coast to coast across Canada, that sort of thing. So with PET imaging in Canada, Canada does fewer PET scans per capita than most European countries, but it's something that's growing a lot. In the last 2 years, we've increased our PET scans per capita by 39%, which is just enormous. So it's about, 120,000 people a year are being diagnosed with PET scans. So sort of, 1 out of every 300 Canadians gets a PET scan every year. Right now, we've got 57 PET scanners coast to coast. That's up from only 51 PET scanners a couple of years ago. So again, this is something that's growing. There's a number of different radiopharmaceuticals or molecules that you can use for this. Most of them are based on F18. The main one is that radioactive sugar that we've looked at. So PET usage in Canada is about 80% for cancer, and it's 80% FDG. The secondary usage is for cardiac imaging, and that's usually an isotope called rubidium-82. Typically, fluorine-18 is very short-lived. It's got about a 2-hour half-life, so you typically make it on site, which is why on the right-hand side of the slide, you'll see the locations of PET scanners in Canada and the locations of cyclotrons in Canada. And you'll notice they do line up somewhat. You typically will have a cyclotron located nearby where your PET scanner is, to make sure that patients have access to the radiopharmaceuticals they need, not only to the PET scanners. Next slide provides you with a similar sort of quick overview of SPECT imaging in Canada. Again, the PET versus SPECT is just about the particular isotopes you're using. SPECT is much more standard in Canada. We're at 1.2 million imaging scans per year, so there's 10 times as many SPECT scans as PET scans. And even this is rising about 9 or 10% a year. Utilization of SPECT is very different than PET. So with PET, it's 80% oncology and then some heart imaging. SPECT utilization is all over the place. So the main single most important usage is still those cardiac stress tests we mentioned. Musculoskeletal, so that's imaging with phosphate-based agents to look at abnormalities in the skeleton and so on. Oncology, but it's also looking at lymph nodes. It's looking at people's thyroids. It's looking at how well your kidneys are functioning, how well your liver is functioning. So SPECT agents, just technetium drugs alone, there are 18 different technetium-based imaging agents that are approved for use in Canada. So there's an enormous number of different drugs that are used for this application. Yeah, next slide. So where do these diagnostic radioisotopes come from? I sort of already mentioned fluorine-18. We'll start with technetium. Technetium-99m is the most widely used diagnostic isotope in nuclear medicine. So when we're looking at those SPECT scans, the 1.2 million a year that we're doing in Canada, at least 1 million of those are technetium scans. We don't have the exact breakdown, but it's by far the most widely used isotope. It's not something that's currently produced in Canada. There are about 10 research reactors around the world shown on this map that take enriched uranium, put it in the nuclear reactor to make it fission, then dissolve that enriched uranium and chemically separate out molybdenum-99 because molybdenum-99 decays to technetium. So molybdenum-99 is just a different radioisotope. It's loaded onto what they call a generator, which is basically a column of alumina. I've shown a cutaway version of a of a generator here, and then also what they actually look like when they're packaged to be distributed. So what you do is you stick the molybdenum-99 on this resin column and you put some lead around it, and you ship that out to hospitals. The molybdenum decays to technetium slowly over a period of about 2 weeks. And every day the technologists at the hospital can go in, they can run some fresh saline through their generator, and the technetium washes off into their vial, and they can use that to produce patient doses of radiopharmaceuticals. So technetium is a bit of an oddball. It does have a different production route than really any other radioisotope that's used in nuclear medicine. So there's this network of 10 research reactors, and there's about 4 or 5 different processing facilities around the world. Again, none of them is in Canada, where they're processing that enriched uranium and separating out the medical isotope to be manufactured into these generators. So by the time the generators come to Canada, it's just Moly-99, which has got a half-life of several days. And the hospitals use the generators for about 2 weeks, and then they send them back to the manufacturer to be disposed of. Next slide. Our next slide looks at something that's a lot more typical. So I mentioned with F-18, all the cyclotrons across the country, there's about 24 of them. Almost all of them produce fluorine-18. And this is just for your interest. This is what a typical hospital cyclotron would look like. This is the one we have on our campus. So the left-hand image is, you can see the sort of copper coils. Those are the coils of the cyclotron where you're actually accelerating particles. You can attach things onto that, and you attach things like on the top right side, I've got something that says titanium target. That's basically a little jar that you can put your water in. You attach that onto the cyclotron, it bombards it with protons, and you make fluorine-18. The cyclotron is about as tall as I am, which doesn't really help because you can't see me in person. The cyclotron's 5 or 6 feet tall. It's about the size of a typical adult, so it doesn't take up a lot of space. It's in an underground vault so that it's got shielding around it, and you can actually run the radioisotopes from the cyclotron directly into these large lead-shielded hot cells that we're showing in the center of slide. That looks like what we're seeing on the right-hand side when there's people actually in there doing radiopharmaceutical manufacturing. So the medical isotopes come from the cyclotron into the hot cell. You have a bunch of skilled technicians who are manipulating them, attaching them onto the drug molecules, and distributing them. So basically, all of your radioimaging agents or radioimaging isotopes except Tech-99m are generated in cyclotrons. Some of them are generated on site, like coast to coast, in these 24 different cyclotrons. A lot of other ones, like gallium-67, indium-111, rubidium, germanium, these are generated at larger cyclotrons, sometimes in Canada, sometimes not. Canada does have a big privately owned cyclotron facility in Vancouver owned by BWXT. Where they have higher power cyclotrons that can make a wider range of medical isotopes. Some others are imported from around the world, but these are all cyclotron generated medical isotopes. So you're starting off with a stable isotope, you're adding a proton, you separate out the radioisotope, and you deal with the waste stream that you've generated. Yeah, I think that's what I wanted to say about the diagnostics. If we could move on, we'll talk briefly about some of the therapeutic applications of radioisotopes. And there are many of them, and we won't do too much detail on them. So our next slide actually shows us, it's one of my favorite slides that I like to show, especially to students. A lot of people don't know that the use of radioisotopes for therapy goes back over 100 years. So on our next slide, we'll actually see some of the earliest uses of radioisotopes to treat cancer, which was also some of the first effective treatments for cancer. So Mary Curie discovered radium back in 1898. By 2 years later, someone had discovered that if you put radium on your skin for too long, you get a burn. And 2 or 3 years later after that, some clinicians had discovered that if you make a source of radium and you hold it deliberately near a patient's cancer, you can successfully destroy cancer. Okay, so this is the first effective treatment of cancer other than surgery. Right? Chemotherapy didn't become a thing until the 1950s and 60s. Right? External beam radiation therapy is also the 1950s. So the first successful treatment of cancer was using radium-226, little sealed sources of radium-226 that you could insert near the cancer site for a short period of time to deliver an acute toxic dose of radiation and then remove them. So the next slide shows where we've gone since then. Some things look pretty similar, some things look quite different. Nowadays, exactly what we talked about on the previous slide is called brachytherapy. And more than half of Canadian radiation therapists use brachytherapy, sometimes in conjunction with, your typical external beam radiation therapy, sometimes instead of it. What we have now is a very, very, very tiny source, the size of a needle. And then we have a series of applicators, which is what we're shown on the right. So for example, at the top right, if you had someone who had a tumor in their nasal cavity, this is an applicator that you would insert into the nasal cavity, and then the little tubes that are running at the bottom of it, we would fire in our little tiny radioactive source from an afterloader, which is shown at the bottom of the screen. So you can fire the sample in, the radioactive source in, you can leave it there for 2 seconds, 5 seconds, 10 seconds, whatever your treatment plan recommends. And then you'd have that source return down into the afterloader where it's being stored in a shielded environment. So this brachytherapy is something that's been used to increase survival rates in a number of different types of cancer. Nowadays, nobody uses radium-226. Instead, we're using iridium-192. This is a radioisotope that's generated in nuclear research reactors. So you buy very high purity iridium wire, you put it in the nuclear reactor, you add some neutrons to it, it becomes radioactive. For processing, all you're doing is taking iridium wire and you're putting it inside a titanium cylinder and you're welding it shut. So there's no waste stream. It's really a very, very simple process. Next slide just shows an alternative to that. So when we're looking at those iridium things, we're taking a radioactive source, taking it in and out of the tumor very quickly. Another thing you can do is you can take sources that have much less radioactivity in and actually implant them permanently at the disease site. So this is a technique known as low dose rate brachytherapy, and it's been held responsible for increasing the survival rate of early stage prostate cancer significantly from the 1990s to 2015, which is when it sort of became the standard of care. So nowadays it's used to treat, particularly in China, it's used to treat a much wider range of cancers because it's very cheap. It's about $1,200 a treatment. It takes a couple of hours of time, and it's very, very effective. So the radioactive material is made into a little tiny source that's being shown on the person's finger at the top right of your screen. The source is small enough it fits in a needle. You can actually string them together into long needles of brachytherapy sources and insert them into the patient as necessary. The next couple of slides are just going to show, for your interest, what it looks like to make this sort of an isotope. So these are some pictures that I took at our research reactor here at MAC. MAC's actually the world's biggest producer of iodine-125, which is one of the 2 commonly used isotopes for this technique. So we start off with some xenon gas. You put it in a cylinder. One of our reactor operators takes that and puts that down in the core of our nuclear reactor. So the blue glow is the core of the reactor. And anywhere where it's blue and glowing, there's lots of neutrons available. After the xenon has absorbed neutrons, it's radioactive, and you can start to separate out the radioactive iodine from the xenon gas. And so our staff do this in specially designed workspaces with breathable air, so on, and remote handling tools so they're not touching things with their bare hands. The next slide just shows the end of that process. So you're working in this environment, so you've got a room within a room with separate ventilation, a breathable air hood, and we're packing up material and sending out solutions of I-125 every day of the week, sending them all around the world so that they can be manufactured into brachytherapy sources. So our next slide is our last slide on this brachytherapy topic, just to show you what it looks like for the clinician when they're doing treatment planning in a hospital. So they have little tiny seeds. They're using a computer program to image where this person has a tumor and to figure out how many radioactive seeds should we put in, where should they be located, and to line up to make sure that you're getting the right radiation dose to the right part of the tumor. So brachytherapy is a pretty standard treatment for prostate cancer. One of the most interesting things going on right now to me with low dose rate brachytherapy is there's a new clinical trial in northern Canada to look at using brachytherapy for women with early stage breast cancer. One of the problems we have in Canada is that people who live in remote regions don't often have worse outcomes when they're diagnosed with cancer than people in southern Canada. So one of the reasons they've discovered for this is that women often who live in remote regions often will be prescribed a course of radiation therapy, and that might be 6 or 8 weeks long, and they don't always complete that course of therapy just because they can't walk away from their life for 6 or 8 weeks to sit in a hospital. So there's a clinical trial going on right now using palladium-103 brachytherapy instead of a 6 or 8 week course of radiation therapy. So perhaps what you do instead is you have a woman who travels once to the hospital. They do the surgery to remove the primary tumor. And then instead of saying come back for 6 to 8 weeks twice a week, you simply implant the little tiny little tiny needles around where the tumor was. Takes about an hour, and that's a permanent radiation therapy. Right, so your cost is still less than $3,000 a patient, but it's done in an hour rather than over a period of weeks and weeks. Our next slide is something that's still a rather niche application. So brachytherapy is the standard of care for many, many types of cancer in Canada. There's something new that's coming down the pipeline, radioembolic therapy, which has been in development for the last 30 years. It's something that's been designed specifically for treating liver cancer, but it's now in research to treat things like pancreatic cancer, brain tumors, and so on. So this is a concept that's designed for highly vascularized tumors. The idea is you take a bunch of little tiny radioactive microspheres and you use them to cut off the blood supply to a tumor and then to blast that tumor with damaging radiation. So on the next slide, I'll just show you what the production process looks like. The microspheres are made in non-radioactive production facilities around the world, and they're shipped to a nuclear research reactor. So they might be little glass beads that are in a glass vial, or they might be plastic in a plastic vial. Either way, you take them, you put them in the nuclear reactor to form the radioisotope. Then they go to a clean room facility where they do quality control testing and dispense patient doses. So again, this is something else that really doesn't have much in the way of a waste stream, other than some leftover microspheres if there's too much activity for the patient, which you would then decay store on site. So this to me is an exciting therapy. It's exciting to see people trying to combat diseases, especially like pancreatic cancer that right now has very, very poor patient outcomes. The final topic for today, I am conscious of time. I know we started a few minutes late, but we will still try to wrap up on time. The final application that we're going to talk about today is something called therapeutic radiopharmaceuticals, sometimes called targeted internal radionuclide therapy. You might have heard of this now as targeted alpha therapy or radioligand therapy. These are all terms that basically mean the same thing. And what these are is trying to come up with an effective treatment for cancer that's already spread. Okay? Brachytherapy is wonderful if you know where the tumor is and it hasn't spread to multiple sites in the body. Same with radioembolic therapy. It's great if you've got a tumor in your liver. It's a great treatment for that. But if you have systemic disease with multiple cancer sites throughout your body, it's going to be very, very, very difficult to treat that with surgery or with brachytherapy or whatever, just because there's multiple sites. So what we want to be able to do is to develop a way to treat cancer that's already spread. And the first time this was done effectively actually is as far back as 1942. This is just playing on the fact that your thyroid has an enormous affinity for iodine. So one of your thyroid's main function in your body is to take iodine from your blood that you've gotten from your foods, and to take that iodine and put it into your thyroid, where it gets manufactured into thyroid hormones that are important for metabolism, hormones, et cetera, et cetera. So iodine is thyroid seeking, just naturally, inherently. When you eat iodine in your salt, it goes straight to your thyroid. So if you have thyroid cancer, you can ingest radioactive iodine. That radioactive iodine will go to your thyroid and will destroy the tumors in your thyroid. And it turns out that even if that thyroid cancer has spread to other parts of your body, the iodine will still seek out those other parts of your body because they're still essentially thyroid cancer cells. So they still have a high affinity for iodine. So the first successful treatment of metastatic thyroid cancer, or metastatic any sort of cancer really, was the use of radioactive iodine, I-131, goes back to all the way to 1942. So our next slide will look at a couple of more modern examples of that. It's exciting, right? It's really exciting to be able to just treat systemic cancer. And it spurred a lot of research in the 1980s, particularly around people who have metastatic cancer. It often spreads into your bones. We had that example of the technetium imaging scan before of the person with the lung cancer patient with bone metastases throughout the skeleton. These skeletal metastases can be fatal. They can also be very, very painful. So there's been a lot of interest in disguising other radioactive isotopes as phosphate. Kind of the same concept what we did with the technetium, except now instead of using an imaging isotope, we're going to use therapeutic isotopes like samarium or rhenium. So strontium, samarium, these are all reactor-produced radioisotopes. They're made in nuclear research reactors. And then you put these sort of phosphates around them to disguise them so that they get taken up by the parts of your bones that are growing rapidly, in other words, bone cancer. So that's the 1980s. Our next slide talks a little bit more about some groundbreaking work that was done in the last decade of the last century. And what really happened is there have been huge advances in molecular biology that's helped us to better understand how you can develop a molecule that seeks out cancer. So things like antigens, antibodies, receptors. Once we start to understand the biochemistry of cancer cells and how cancer cells are different from healthy cells, we can find molecules that will seek out cancer cells wherever they are in the body. And then you can attach on a radioactive isotope that will destroy the cancer. So the first antibody-based drugs, Bexar and Zevalin, are approved for use in Canada. Bexar is not on the market anymore. Zevalin is. I don't know of many patients who get Zevalin in Canada because there are other therapies that also treat that non-Hodgkin's lymphoma. Same with the samarium-153 drug. Quadramet is available on the market in Canada. I don't think it's that commonly used. Our next slide shows where we're at right now. Some people are calling this a renaissance in radiopharmaceuticals. What it really is the massive advances that we've made in understanding cancer biology in the last 20 years are now being leveraged to help us understand how to treat very specific types of cancer. So the right-hand side of your screen is showing you a schematic of what a targeted radiopharmaceutical would look like. So on the extreme right, we have a cancer cell that has a particular protein sticking out of it. What is that protein? That's going to depend on what type of cancer you have. But you're going to pick a protein that is only expressed on cancer cells, not on healthy cells. Then you're going to work with some biochemists probably and chemical biologists to help you figure out what molecule will bind to that protein. Then you've got to call your friend the chemist and say, okay, well, we've got this molecule that seeks out cancer, and now we need to attach a radioactive isotope onto it. Can you help us do that? So it's a very, very, very collaborative development process that starts with biology and ends with people working in a nuclear reactor to make the radioactive isotopes that you can attach to the molecules that seek out cancer. So we're hearing a lot of talk around lutetium-177. This is how lutetium-177 radiopharmaceuticals work. Lutetium itself is not, it's not cancer seeking all by itself. You have to attach it onto a molecule that goes and seeks out cancer. So lutetium has been used in Europe since the 1990s, particularly for neuroendocrine tumors. It's been in Canada for a few years now. What everyone's really excited about is a few months ago, lutetium PSMA 617 was approved by the US FDA, the European Medicines Agency, Health Canada. This is exciting because PSMA targets prostate cancer. Neuroendocrine tumors, of course, we want to be able to treat. Neuroendocrine tumors are quite rare, whereas prostate cancer we know is one of the leading causes of death in Canada. Or sorry, one of the most prevalent cancers in Canada. The survival rates are actually fairly good. But there are lots and lots of people around the world who have metastatic prostate cancer who would like to have better treatment options. So by developing that molecule that seeks out prostate cancer cells and attaching on a radioisotope, you can treat cancer patients who have cancer spread throughout their bodies. And there's more and more of this work going on in universities around the world and all across Canada. People who are identifying the new biological targets, such as proteins, looking at using different isotopes and so on. There's a lot of talk about actinium-225 coming down the pipeline. Our next slide is just an example of why this matters. Our next example is just showing you this is what the structure of these types of things look like. So this is lutetium dotatate. So this big organic-y looking thing here is the peptide that seeks out neuroendocrine tumors. The green part is how we're attaching the radioisotope onto that peptide to direct it to the disease site. And it's our next slide that's going to show you what the power of these types of treatments are. So before we treat a patient with any sort of drug, we want to know if they're going to respond favorably to this drug. The real push nowadays is for personalized medicine. It's great to know that, 8 out of 10 people respond to Advil, or, 3 out of 4 dentists recommend whatever it is. What we really want to know is, what about me? What about the individual patient in front of me? Is this person's individual, specialized, personal disease going to respond to this particular treatment? This is important because we don't want to waste people's time by prescribing treatments that aren't necessarily going to work for them. And also, we're going to save the healthcare system money by not prescribing treatments that aren't going to work for people. Medical isotopes provide a really powerful way of assessing this. Because don't forget, we can do diagnostic imaging just as well as we can do therapy. So we can make a drug, like the one shown here, that seeks out neuroendocrine tumors, and we can attach different radioisotopes to it. We could attach gallium-68, indium-111. We could attach an imaging isotope to it and administer it to a patient and see if it gets taken up by this individual patient's cancer cells. Not just a statistical average of most people respond to this. Will this patient respond to this? So this is a case study that was published a couple of years ago. This is a patient who's got Merkel cell carcinoma, which is a neuroendocrine, it's a type of skin cancer that's neuroendocrine in origin. And there's not really a viable treatment program for this person. But the consulting physician said, well, technically on paper, this should be a neuroendocrine tumor. So maybe it would respond to Lutathera. We don't know if it's going to because they'd never studied Lutathera in Merkel cell carcinoma patients. So what you're able to do is to make an imaging version of that drug, give it to the patient, and as you can see in the image A on the left, there's massive uptake of this tracer throughout the patient's torso. So this is showing us basically little bits of Merkel cell carcinoma that have spread throughout this person's body. And the prognosis really looks quite terrible based on that. But based on this, it's showing that this person's cancer will take up this drug. So then we make the lutetium version of this drug. We administer it to the patient. The image doesn't look quite as good. It's kind of blurry. Lutetium is not great for imaging. It's really useful for therapy, though. So after the patient has had a couple of doses of the lutetium-based drug, we repeat the imaging study that we did on the left-hand side. And what we get is the image that's shown as image C on your right-hand side. So we've gone from having a patient who's got dozens and dozens of little cancerous metastases throughout their torso to the image on the right-hand side where really all we're seeing is kidney and bladder uptake. In other words, the radiotracer is just being excreted through the urinary system because it's not being taken up into tumors because the tumors aren't there anymore. Okay, so this shows you the power of how we can use diagnostic imaging to assess which patients are going to respond to treatment, and then to treat them, and then to make sure that they've been treated effectively afterwards. I got this far in my planning my presentation, and I realized I haven't talked about power reactors. So our last couple of slides, we'll talk about power reactors. So where are power reactors in all of this landscape? We haven't talked about them. Power reactors are really something that's new in the nuclear medicine space. Our next slide shows what the traditional role of power reactors is in the sort of medical isotope type space. So many of you will know that CANDU reactors are major producers of cobalt-60. Cobalt-60 we don't usually refer to as a medical isotope because it's not being used in patients. Typically, cobalt-60 is used for sterilizing things. So when you buy a pack of Band-Aids and it says they're sterile, that's because someone has exposed it to large amounts of ionizing radiation to make sure there's no bacteria in it. When you go into the hospital and they hook you up with IV tubing, that IV tubing has to be sterilized before use, often with cobalt-60. Things like artificial joints, hip replacements, and so on. This is typically things that are irradiated with cobalt-60 ahead of time to make sure that you don't introduce bacteria and germs into the patient. Cobalt-60 used to be used for radiation therapy back in the 1950s and 60s. It's really been discontinued since the 1990s. We tend to use linear accelerators now, not radioisotope sources. But Canada is about 50% of the world's supply of cobalt-60, and it's a tremendously important isotope for sterilizing medical supplies, if not for direct use in human treatments. So our next slide is our last slide, and it talks about where power reactors are going in this landscape. There's been a lot of talk about this the last couple of years. We've been in the world nuclear news about disruptive Canadians doing exciting things that no one else is doing. And this is reflective of the amount of innovation going on in Canada in this space, where we're actually have groups that are actually designing irradiation systems to take things in and out of our CANDU reactors while they're operating, so that we can use the CANDU reactor as a source of neutrons. I showed a few pictures of our nuclear research reactor at MAC. I said the blue glowing part is where the neutrons are. CANDU reactors are also full of neutrons. So if we could access those neutrons, we can use them in the same way we use a research reactor, except that power reactors are much bigger, just physically bigger. There's more space and there's more neutrons. So you can produce larger amounts of radioisotopes. So Bruce Power has talked a lot. They're now starting irradiations of ytterbium-176, which they're going to export. And people in Europe or the US are going to be separating out the lutetium and then sending that on to drug manufacturers. OPG has talked a lot about they're doing neutron irradiations of molybdenum. This is an exciting technology because what they're doing is they're generating technetium-99m in generators, but they're doing that without using enriched uranium, which is a very, very exciting development. So they're irradiating the molybdenum, sending it just next door to BWXT to be manufactured into this new proprietary generator that they've designed. So I hope on our last slide, which is just one more, I hope that I have tried to answer at least most of the questions that you guys posed to me. How do we benefit from nuclear medicine? It provides personalized diagnosis and treating plans for more than 1 million Canadians every year, right? Primarily in oncology and cardiac disease. As we're getting more and more of these receptor-targeted radiopharmaceuticals, it's moving from just being standard of care for cardiac disease to being able to treat really advanced metastatic diseases. So it's really a game changer for cancer patients. There had been a couple of questions about, cyclotrons versus reactors and so on. Cyclotrons and nuclear reactors are complementary. They make medical isotopes in different ways. One adds protons, one adds neutrons. So you get different medical isotopes out of them. So you can't replace cyclotrons with nuclear reactors, and you can't replace nuclear reactors with cyclotrons. They make different things. And they're both super important because your diagnostic isotopes tend to come out of your cyclotrons and your therapeutic isotopes tend to come out of your nuclear reactors. So nowadays, when we're talking about therapeutic radioisotopes and we're talking about nuclear reactors, we're talking about research reactors. There's about a dozen research reactors around the world that are major producers of at least a half a dozen different therapeutic isotopes. And that may be changing as the nuclear power sector starts to move on from focusing exclusively on cobalt-60 to using some of the sort of spare neutrons in the reactor core to generate things like lutetium-177 and also diagnostic things like technetium-99m. So my final slide has my email address and my contact information if anybody would like to get in touch with me either now or in the future. These are just some images of our facility. We have a cyclotron, a nuclear research reactor, and we're happy to have visitors come by anytime if you're in the neighborhood. Please do get in touch. I'm happy to give anyone a tour anytime you're interested. And with that, I will thank you very much for your attention, and I'll answer any questions that you may have.
Testing.
Oh, I heard that. Someone said testing. I heard that.
Okay, is it not true that you do not need the isotopes for medical use from a nuclear power generating station, that you can produce them from nuclear reactors, the smaller nuclear reactors, as well as the cyclotrons?
Yeah, that was a little bit patchy. My understanding is that the question is it true that you can generate all the isotopes you need using research reactors or cyclotrons, not power reactors? I would say yeah, that's true. That's how the world has been for the last sort of 50 or 60 years. So cyclotrons for imaging isotopes and all of your neutron-rich isotopes that are so great at cancer therapy, right now and for the last 30, 40, 50 years, they have all been coming 100% from nuclear research reactors. That's not to say that that's good or bad, though. One of the things that research reactors will struggle with as we're starting to come up with therapies for mainstream diseases like prostate cancer is capacity issues. You may come up with an issue where if you really do have a couple of million people every year who have metastatic prostate cancer and you want them all to have access to therapeutic radiopharmaceuticals, having larger scale production facilities may provide a big advantage there. What a power reactor has that a research reactor doesn't is in some cases higher neutron flux, so more neutrons bumping into your sample every minute, and higher volume. What a power reactor doesn't have is a lot of flexibility around the types of materials that can go inside of it. So a nuclear power reactor is very hot, just physically hot. The temperature is high. There's a lot of gamma radiation and so on. So for example, at MAC, where we're putting xenon in a chamber and putting that in our nuclear research reactor, you aren't necessarily going to be putting a gas inside of a power reactor. So a power reactor is going to be more restricted in terms of what types of irradiation targets you can put inside of it, just because it's got those harsh conditions on the inside of it. So it is true that yes, any neutron-rich isotope you want, you can make in one of the world's nuclear research reactors. I do worry about capacity being an issue eventually, if that answers your question.